Tina, what's a variant of basal cell that we are concerned about?
So that's not your typical nodular type. Trying to remember.
So you notice in multiple small fingers of basal cells surrounded by fibrovascular connective tissue in between. This is a morpheoform. And the reason why you have to remember this is if basal cells are going to spread locally, it's usually the morpheoform that does it because these send little fingers out, so you can't normally see them and remove them all. The nodular type, which is most common, or nodular cystic, you can see the edges, you can cut it out, usually. But the morpheoform type sends these little fingers out, and it's often difficult to find the exact margins. So the morpheoform type is the one that's more difficult to remove because you may be leaving remnants of tumor behind. All right, this is what happens when you let a basal cell grow for 10 years. So this is a basal cell. It was left alone for 10 years. This is a rancher lady from Nevada. She had a morpheoform basal cell 10 years ago. They said, we're going to have to do more surgery, remove that. She said, I'm an old lady, leave me alone. Went home, and then 10 years later, her daughter brought her back because she had a little piece of Kleenex stuck to it and it smelled. And there was actually CSF dripping out. So if you let basal cells grow for 10 years, they can cause really bad things. All right, what are we seeing right here, Teresa?
Lesion on the upper eyelid. Looks like it's kind of yellow-orange.
A little orange, kind of crackly parchment paper look to the surface.
Yeah.
What would you be concerned about here?
So, looks like there might be loss of lashes, but it's hard to say. So, moving in the squamous cell.
All right, so you'd be concerned about a squamous cell. Does this confirm the diagnosis?
Yes.
So what do we see on the path of a squamous cell?
So, there's keratin pearls. There's cells with higher NC ratios, prominent nucleoli, and they're just like diving through the tissue.
Okay, so you can see here these nice squamous pearls, squamous whorls in here. That's a real tip-off for a squamous cell. Extra bonus points. If a squamous cell spreads from the lid back, how does it spread?
Perineural.
Perineurals. That's important. You really want to watch them because they can spread perineurally. All right, what are we seeing right here?
There's a dark kind of pigmented lesion on the upper lid.
Okay, what would you be concerned about?
Maybe like seborrheic keratitis versus melanoma kind of thing.
All right, there's enough here to tell you the difference between the two. If you had a 50-50 shot here, what would you guess?
Let's go seborrheic keratitis.
Oh, 50-50 chance.
Let's go melanoma.
Okay, so basically when you look at that, you see loss of lashes, you see it's thickened and irregular, you see variable coloration. So whenever you see that constellation of findings, you really worry about melanoma. And so the melanoma is not uncommon, or not common in the eye, it's becoming more common. And so as the sun worshippers of the baby boom generation get older, melanomas are sadly popping up more frequently. And here we look at the melanoma cells. They may not necessarily be heavily pigmented when you look at it, but you can see there's nucleoli, there's clumped chromatin, there's pleomorphism, there's different sizes and shapes of the cells. So that's malignant melanoma, and these can not only spread locally, but can metastasize. All right, what are we seeing right here, Chris?
So here we see, at least from a photo of the eye, there's kind of injection on the conjunctiva, and the whole lid margin just seemed really swollen. This would make me think, differential-wise, maybe like a sebaceous cell carcinoma could look something like this.
All right, so sebaceous gland carcinoma is the great mimicker. You got to remember that, so don't be fooled. So this was called blepharoconjunctivitis, treated with antibiotics. And so what you look is, if you look at that upper lid, look at the loss of lashes, look how thick it is. You can even see the yellow from the meibomian secretions that are there. And so this can look like a chronic chalazion if it's locally. If it's diffuse, it can look like blepharoconjunctivitis. And so this is the great mimicker. You want to be very careful not to miss these because, again, these can metastasize. And when you look at them, these can be very aggressive looking and they behave very aggressively. They've got mitotic figures, they've got nucleoli, there's still occasionally little dots of lipid in them, but these can be a very bad actor and these can spread also. So you want to not miss a meibomian gland carcinoma. All right, so here we have, this is not Mo the surgeon, this is Mo the stooge. Come on. You study better when you're not so tense, so chill, okay, chill. All right, conjunctiva, so softball here, Brad. What are the three parts of the conjunctiva?
So you have the non-keratinized stratified.
Oh, the three areas of the conjunctiva.
Oh, areas, sorry. Okay, so you have the bulbar, the palpebral, and you have the fornix.
Exactly. So it starts lining the, from the limbus, lining the bulb, the bulbar, and then the fornix, and then lines the lid, the palpebral. And then, so what are the different layers now of the conjunctiva?
So we have the non-keratinized stratified squamous epithelia. We have the, I guess the subepithelial layer. Like
Yeah, we call that the substantia propria. Substantia propria. What are all those little dots down there in the fornix?
So those are probably goblet cells.
Exactly. And what do they make?
Mucin.
Mucin. All right, very good. So mucin, the inner layer of the tear film. All right, what do we see in right here? You're not graduated yet, so what do we see in here? The pterygium. And so what's the difference between a pterygium and a pinguecula?
Pterygium crosses the limbal margin.
Exactly. So pathologically, they're exactly the same. It's just that the pterygium crosses the limbus onto the cornea. What do we find pathologically?
Solar elastosis.
All right, so that's that squiggly solar elastosis of the collagen and substantia propria. What else do we find more anteriorly?
What's it called? Just the, it's like the connective tissue that, elastin, is that it?
It kind of stains blue, so we call it basophilic degeneration. And so they're both solar elastosis, basophilic degeneration, UV-induced degeneration of the tissue underneath.
Elastoid, is that the same? It's all
Solar elastosis is it's the breakdown of the collagen tissue. It gives it elastic characters and like a frayed elastic look.
and then elastoid degeneration.
Same thing. Yeah, same thing. Yeah.
Sometimes I feel like the pinguecula look thinner and more cystic than pterygia that have obviously crossed.
Well, pterygia can sometimes become more fibrotic with time. So as they grow more, they can become more fibrotic, and that's what you're seeing, I think, is more fibrosis underneath. Whereas when they're first starting, they are a little bit more translucent and seem a little bit more cystic. All right. What do we see in here? Does this give you concern?
Yes.
The question is, why?
What was that too?
Not because it says tumor up there, that's not a hint or anything.
Just because it doesn't look very discreet. It's thickened, it has this cystic, reflective appearance.
Yeah, remember when you look at a pterygium, the epithelium is actually thinned rather than thickened, and the meat of the tissue is underneath it in the substantia propria. If you look at this, that epithelium is thick and gelatinous. So the epithelium is the thickened part, and it's really gelatinous. And so what would this be concerned for? Yeah, this would be concerned for CIN or even squamous cell carcinoma, depending. And so when you see this gelatinous, thickened epithelium, you have real concern about that. And we look and we see this picture. So does this help our diagnosis?
Yes, because you don't have the normal layers that you would expect to normal tissue.
So if you look right there, you'll see loss of normal maturation. You see nucleoli. You can see different sizes and shapes. And so this is what we call CIN, conjunctival intraepithelial neoplasm. And we grade it mild, moderate, severe, depending on how much of the thickness from the base up is involved. So lower third, mild, up to 2/3 moderate, more than 2/3 severe. So this would be severe, it's full thickness, but by definition, the basement membrane is still intact. And so if it goes beyond the basement membrane, that's when we say squamous cell carcinoma. As long as the basement membrane is intact, we say CIN. And you guys have to read whatever the latest literature says. We call this, ocular surface, OSSN. So, and again, just because you memorize something, about every 10 years they change it all, so you have to rememorize it all. And I think it makes it more confusing rather than less. But in any event, you have to know what's in the BCSC, and that's how you do the nomenclature.
My last question.
Yes?
What exactly is Bowman's disease? I know it's like squamous cell, like in situ.
Yeah, Bowman's disease really is an old term, and I don't think you're going to have it pop up anywhere. Hopefully not in your readings. All right, so what are we seeing right here? Becca?
So, this, I think this is still conjunctiva, but it's very disorganized. There's some keratin whorls in there, and some prominent nucleoli you can see inferiorly.
And these are actually in the connective tissue under the conch. So this has now become, or technically squamous cell carcinoma. So this is actually a superficially invasive squamous cell. It looks like the squamous cell of the lid in that it's got keratin whorls, keratin pearls, nucleoli, pleomorphism, and so this is an invasive squamous cell carcinoma of the lid. What are we seeing right here, Tina?
So there's some localized areas of pigmentation sort of on either side, just next to the limbus and the palpebral fissure. So you'd be thinking about a couple of things. One would just be sort of racial pigment, and the other would be PAM,
Okay, what does PAM stand for?
primary acquired melanosis.
And how do we break down PAM? What are the two ways we describe
So
it?
with and without atypia.
All right, so what would this be?
So looking at those cells, trying to see, it looks like there's a couple of nucleoli, but it's not looking like it's kind of full thickness. It's
If you look,
definitely-
these melanocytes are mostly here in the basilar layer. Ignore the squamous cells above it, but they're mostly in the basilar layer. And so when you have PAM without atypia, the melanocytes are along the basilar layer and they don't show atypical features. And even racial pigmentation will look like this. So you can often see people who are African American or Asian who will have pigment around the limbus. And this is PAM. It looks exactly like this, PAM without atypia or even racial pigmentation. Does this give you more concern?
Yes.
Why?
It looks like it has, like the conch vessels look like they're coming in and spreading out, like feeding the lesion.
And the other thing you can see, this isn't just that nice superficial brown dusting. There's some areas of darker pigmentation, there's some areas of lighter pigmentation, there's some thickening. So this would be a bit more concerning. And when we look at this now, what would we call this?
Melanoma, inside you probably.
Or, again, this we could still technically say PAM with atypia, exactly. So these atypical melanocytes are now spreading out through the epithelium itself, and they're becoming more atypical themselves. They're not just benign melanocytes. And so PAM will go through a phase where you get PAM with atypia, and it's important to recognize that because PAM with atypia can go on to malignant melanoma. PAM without does not. So this is technically a pre-malignant lesion. So PAM with atypia. And is this concern?
Very concerned.
So even an intern can recognize this. What would your concern here be?
For like a melanoma.
Exactly. So this is melanoma. Unfortunately, another patient at the VA kind of ignores it as long as he can until he comes in. And this turned out to be an actual malignant melanoma of the conjunctiva. So if you don't, you got to watch the PAM with atypia very carefully because, if you look at malignant melanomas, about 80% of them arise from pre-existing PAM with atypia. Now, it doesn't mean 80% of PAMs go on to melanoma. It means if you have melanoma, 80% of those arise from pre-existing PAM. So it's important to watch them real carefully. You could get a malignant melanoma.
What's the time look like? Is it like years?
You know, oftentimes it can be years, and these will often flare and then subside and flare and subside. So you'll see these people, there'll be areas, you'll remove them, you'll grind them, treat them, and then they'll come back a year or two later and they'll have another one pop up somewhere else. And so you really want to be careful. So this is the Parthenon on top of the Acropolis. They've been rebuilding this for a long, long time. It's nice though, every few years when I go back, they've got another, you know, part of the wall or the ceiling of them. So the Greek government's trying to get the so-called Elgin marbles now. One entire face of the top of the Parthenon is in the British Museum. And, you know, Elgin was the guy who rescued them, you know, because those Greeks couldn't take care of their antiquities. And so Elgin rescued them and took them to London where they're safe there. So hopefully someday they'll get them back and finish rebuilding this. All right, cornea. We're going to talk about the cornea. What are the layers of the cornea, Chris?
So we have the epithelium, below that is bowmans, stroma, decimae, and the endothelium.
Okay. Tell me the difference between Bowman's and Decimae's.
So decimae is a true basement membrane, bowmans is not. a true-
Exactly. So what stain could you do to tell the difference?
PAS.
All right, so Bowman's is just a condensed area of the anterior stroma. Bowman's does not regenerate. So if you have an ulcer, you have an abrasion, you have a cut there, it's a good historical marker because it doesn't regenerate. Decimae's, because it is a basement membrane, Decimae's grows thicker throughout life. You know, if you scrape it off, you know, and more endothelial cells can come over and they can lay down new Decimae's membrane. Now, the epithelial basement membrane is not Bowman's. It's a separate little basement membrane in front of Bowman's. So, think about this one. I think this is true. Think about it. So, all right. So, corneal infections. What are we seeing right here, Brad? What is this a classic picture of?
So this is, we have some fluorescein uptake in the pattern of a dendritic lesion, which is classic for HSV keratitis.
All right, so this is HSV keratitis. You've got the dendrite, you've got the little swollen projections. Now, if you were going to take a culture of that, where would you culture it?
On a swab.
I mean, where on the lesion?
Oh, wait.
I got to worry about you. You're way too left brain, so it's way too literal.
You would do the bulbs.
Exactly. So remember now, where the stain is all taken up in the center, that's where the epithelium is denuded already. So if you're going to do a little scraping for a culture, you want to do it kind of at the edge where the thick epithelium is at the edge of the bulbs because that's where the active viruses are going to be. And here you can see an area, there's the ulceration, and then you want to do it right next to that, and that's where the active viruses will be. And you know, don't have time to go into it now, but realize that, you know, there's more than just simple dendritic keratitis. You've got variations of stromal keratitis, recurrent herpes. You really need to know that for when you get to the cornea section of the boards. All right, what are we seeing right here?
So a very inflamed hyperemic eye with the cornea looks like there's some ulceration with infiltrate.
All right, what would you be concerned about here?
Depending on if they're not feeling a ton of pain, and consider we're in the virus section, I consider like a neurotrophic keratitis with the ulcer, but could consider like a bacterial ulcer as well, like Pseudomonas or something.
Exactly. This is someone who actually, you know, didn't take care of their contacts, and so this is a Pseudomonas ulcer. And you really worry about a Pseudomonas ulcer because a Pseudomonas ulcer in 48 hours can actually cause a corneal perforation. Because not only do the bacteria put out collagenases and proteinases and help melt down the cornea, but the body's immune system that comes in there can help melt down the cornea. So you really got to treat these as an emergency. This is a cornea that has become completely necrotic and is perforated. So that's what you really worry about with the bacterial ulcer.
That previous picture, it looks like a central area that's pre-veg.
What's that?
Picture of the pseudomonas ulcer.
Yeah,
The
this,
previous one. Yeah,
It looked like it was thinning already.
oh, it is already. Yeah, this is a Pseudomonas. This is really thinning, and this actually did perf later. And so it is thinning. It did perf. All right. What are we seeing here? This is a little bit different.
Another angry eye.
It looks kind of plaque-like with the ulcer, and it looks like there's a greater area of stromal involvement.
Okay. your concern here be? A little bit more indolent in history. It's been here for about 10 days. Farmer. Exactly. This is a fungal ulcer. And so you see the little kind of halo of white around it, and you get kind of that halo of white around it. It's more indolent, and it's slower growing, and you get that exposure to the crop when you're out there. And sure enough, we do a special stain. What stain do we use for looking at fungi? GMS. So this is Gamorreum methenamine silver. And so the little yeasty beasties will stain a black silver color. So this is your fungal ulcer. All right. What are we seeing right here? Don't say yeasty beasties on oral boards, okay? All right, Becca.
All right, so another angry eye. This one has kind of a ring-shaped infiltrate, and you can see the epithelium is disrupted.
Yeah, big chronic epithelial defect. This has been treated for herpes for 3 weeks.
Yeah, so I'd be worried about a neurotrophic ulcer in this case. But if it was,
Let's say it's really painful.
I might think about acanthamoeba.
Exactly. So when you see a chronic non-healing ulcer and you see this ring of infiltrate around it and it's painful, you often think about acanthamoeba. And sure enough, we stained it, and boy, triple bonus points if you know the stain we use for acanthamoeba. No? Yeah, the Gridley.
Gridley.
The Gridley stain. And so you see, here's the acanthamoeba cysts. And these are really tough to treat because they tend to insist, and so it's tough to get the medication into the cyst. And so, but don't forget, people with acanthamoeba, I've seen it in contaminated contact lens cases. You can get it from soil, you can get it from hot tubs, you know, so don't put your face in a hot tub. If you're hot tubbing it and chilling out, keep your chin above it, you know, don't get your face in the hot tub.
The Gridley stain only works if you have like an actual corneal specimen.
Correct, you have to have a biopsy. Yeah, it doesn't work on a swab, you have to have a biopsy in order to do it. All right, so speaking of contacts. All right, now we're going to talk about the anterior chamber angles. We can talk about glaucoma a little bit. So Tina, we're looking in with the goniomere, and we're looking at the angle starting at the top. What's the first thing you see?
Starting at the top, we'd see scleral spur.
Starting opposite direction, starting anterior, I guess, rather than posterior.
You'd see, are we like Schwabe's line?
Schwabe's line. And then what are the ways we just describe the trabecular meshwork when you're looking with the gonio?
So basically the angle of insertion of the iris, you describe what layers you can actually see within the angle.
Okay, but what are the layers? You said the first one was Schwabe's line.
Okay. So Schwabe's line is first, and then we see trabecular meshwork, so pigmented, non-pigmented, and then on the other side of that would be your scleral spur.
Okay, there's your scleral spur, and then lastly it would be ciliary body, or where iris inserts. All right, now this is just, just for students, if I'm ever talking to students, and so, we kind of describe an angle in either open angle, narrow or closed angle, and then recessed or contusion angle. All right, what do we see in here?
Looks like red eyes with maybe a little arcus, and they're kind of like protruding out. And then the pupils are also unequal, the right pupil being larger than the left.
All right, so if you really look, even though this patient's got the chronic dry eyes of every Utah, the right eye is definitely redder than the left eye, the right pupil is bigger than the left eye, and the right eye is more painful than the left eye.
Acute angle closure.
All right, so you'd be concerned about angle closure here. So mid-dilated pupil, red angry eye, painful eye, and sure enough, we put the slit beam on it, and we see. All right, so here's iris bombay. The iris is bowing forward. You put a gonio in there, you'd see that the angle would be blocked off. So this is angle closure. And now you can get angle closure sometimes from just an eye that's narrow with a big lens, or that's hyperopic, or that's small, but sometimes you can get some abnormal blood vessels growing along the surface of the iris. What do we call that?
Well, that's what I said, neovascularization.
Yes, so you can get neovascular glaucoma that can eventually lead to an angle closure. And remember what the causes of neovascular glaucoma are. Chronic ischemia. So you could have a central retinal vein occlusion. You could have a diabetic. You could have an ischemic eye in general. And then you can get abnormal blood vessels growing, and then you eventually get an angle closure with that. Okay, so we want to talk a little bit about glaucoma. And this is always the hardest thing for me, is you look at an eye and you see a myopic eye, and you see that myopic crescent, and you try to say, okay, where is that disc end, and where's the myopic crescent start? This is definitely a cupped out disc. So this is glaucoma, cupped out disc that we've got here. And this is the ultimate end stage. You don't want it to get to this. We want to stop glaucoma before it gets to this point. So this is, it almost looks like a Boston bean pot. So this is excavated here. It's got a little disc going, a little vessel going along the edge, and then it'll disappear. Posterior bowing of the lamina cribrosa, this is end stage glaucoma. We don't want to see this. We want to stop glaucoma before it gets to this. All right, so this is also on the top of the Acropolis. These are the famous 5 maidens. Sadly, maybe the British were right. This is a remake of the statues, because the original statues were so eaten up by the pollution in Athens that they degenerated, so they couldn't put them back out again. So these are exact copies, but they're not the original ones. All right, we're going to talk a little bit about the crystalline lens. And this is just pathologically where the lens sits. All right, so cataracts. Mike, how do we break up cataracts? How do we describe them?
So you talk about like a cortical cataract, and then maybe nuclear cataract, and then like capsular cataracts.
All right, so posterior capsular, anterior subcapsular cataracts. Remember, there can be various different areas that are affected, and that can have some bearing on the prognosis. So if you have a posterior subcapsular cataract, what's the etiology for that? Not usually PSC.
I'm thinking polar, right? Polar's
Polar, you're thinking polar now, just your run-of-the-mill posterior subcapsular. Diabetes, ocular inflammation, and then medications, most commonly steroids. So PSC, people can be on steroids, they can have uveitis can cause them, they can have diabetes can cause them. Nuclear cataracts are usually aging, cortical cataracts are a mixed bag. All right, so this is the ultimate nuclear cataract. What do we call this?
Brunescent cataract?
Brunescent, so brown-like, brunescent cataract. So this is what you see in the third world, or parts of Wyoming, depending. But so this is a brunescent cataract. You're allowed to say stuff about your own kind. You're allowed. Don't send a letter to the dean and say I'm disparaging Wyoming. All right, so I always want to make sure you guys remember that we do surgery with topical anesthesia. Patients hear everything. So one of my favorites, a patient was very astute. I was doing surgery with the second year, and the patient asked me the next day, what is this position 1 you kept saying? Because you guys keep getting so panicked you come off the pedal. Like, position 1, position 1, position 1. I said, what is position 1? You wanted to know what that was. The other thing is I have to stop saying stab incision, because the patient got really perturbed when I said stab. You said paracentesis. So remember, they always hear you whenever you're doing cataract surgery, so don't be talking about the jazz game in the middle of surgery. All right, here's the Acropolis at night, looking at the Parthenon. You're allowed to go up there 1 day a year at night and take pictures. They light it up every night, but you're only allowed to go up there 1 night. All right, we're going to talk about the retina. So when we're talking about the retina, in terms of the different parts of the retina, what are the parts of the retina that we can describe anatomically?
You're not talking about the layers.
No, we'll get to the layers in a minute.
Okay. I mean, you think about the parts that are in between the arcades.
Okay?
So in between the superior and inferior arcade, you talk about what's temporal to the arcade.
What do we call the area within the arcades?
The fovea.
The macula.
Well, yeah.
Of course, the center of the macula is the fovea, and then anything external to that we consider external. So now we want to talk about the layers. What is the, let's start with the vitreous side. So we're going to describe vitreous to choroid. What's the first layer?
Internal limiting membrane.
Internal limiting membrane, next layer. Nerve fiber layer, next layer. Ganglion cell layer.
Inner plexiform layer.
Interplexiform layer. Internuclear layer. Outer plexiform layer. Outer nuclear layer. And then below that, we have the,
Well, we have photoreceptors.
okay, I'll pass that. Below the photoreceptors.
Yeah, the RPE.
RPE, all right, very good. And so know the ramification of the various layers of the retina, know how they are all interconnected. All right, now what are we looking at?
So this is a cross-section of the fovea.
The fovea. And so what goes on in the ganglion cell layer adjacent to the fovea as opposed to the rest of the retina?
It thins out and disappears right above the foveola.
All right, so it disappears. How about adjacent to it?
Thickens.
So the ganglion cell layer, by definition, is more than one cell layer thick in the macula, and that's how the pathologists define the macula. That does happen to be, within the arcades, but that's what the pathologists do it. So, see in the center of the fovea, the cells all, branch out so that light rays can come in unimpeded, and so all those ganglion cells that are linking up with the cones in the fovea pile up adjacent to it, and you go ahead and you get multiple ganglion cells adjacent to the fovea there. All right, so what do we see in this picture?
Lots of exudates.
All right, exudate and?
I'd be worried about any little microaneurysms.
Okay, so in addition to exudates, you've also got dot plot hemorrhages, you've also got flame hemorrhages. Boy, right here, that may even be maybe a little cotton wool spot. Exactly, so enunciate, project. So, cotton wool spot, so this is a diabetic, and so this has kind of all the findings of not only background retinopathy, but even getting into a little bit of preproliferative retinopathy at this point. All right, so what do we see in here?
So those look like some macroaneurysms.
Exactly, so the first thing that you get is you get the vessels affected, the pericytes drop out, you get weakness, you get macroaneurysms, and then eventually you can go ahead and you can get dot plot hemorrhages, exudate right here, you've even got cotton wool spots. What's a cotton wool spot?
It's a localized infarct of the nerve fiber layer.
Exactly, so it's the superficial nerve fiber layer, you get a little infarct there. Eventually that swelling can go down and you'll have a focal defect there, but you don't see anything different. So that's a cotton wool spot, it's on the nerve fiber layer, and so it looks like someone put a piece of cotton on the surface of the retina. All right, what are we seeing right here?
Vascularization of the disc.
All right, so this is NVD, the so-called Medusa's head. Remember Medusa from mythology with all the snakes coming out of her head? So you've got NVD, neovascularization of the disc, and you worry because if you don't treat NVD, what do you get? Exactly, so this is, how do we describe this hemorrhage?
This is like a vitreous hemorrhage.
Well, it's specific shape to it. Come on, you're out on Galveston Bay in one of these. It's a boat shape. Boat. So you go on ships. I'm impressed. You have ships that you go out on. Okay, sailing on ships. So it's flat topped. So you can see it's flat topped and it's got kind of a round bottom like a boat. So this is actually hemorrhaging pre-retinal. So it hasn't quite broken through to the vitreous, but it's pre-retinal. So it's between the retina and the vitreous. And so if you don't treat neo, you can get hemorrhages like this, and then you can even eventually get scarring, you can get gliosis, you can get retinal detachment. All right, so this is the latest, oops, commercial, for laser vision. All right, what are we seeing right here? Chris?
So this looks like a lot of blood. This kind of looks like a blood and thunder type retina to me.
All right, so what does blood and thunder retina usually signify? All right, so this is a central retinal vein occlusion, backup of blood everywhere. It goes from the optic nerve all the way out to the ora serrata and the so-called blood and thunder look. And then here's a picture of the retina that's had a vein occlusion. You can see loss of kind of the inner 2/3 of the retina from that, from the chronic ischemia. What are we seeing right here, Brad?
So we see retinal whitening with what looks to be like a cherry red spot suggestive of a CRAL.
All right. So if you were Dr. Yamani, you could cannulate that central artery and inject in there and make that better. So I was impressed by that. Cataract surgeon cannulating the central retinal artery. That was pretty impressive, I thought. All right, so this is a classic central retinal artery occlusion. Ischemic retina, which is white. Why do you see a cherry red spot?
Because of the underlying choroid.
Exactly, so it's a window of the normal choroidal flow still showing through, and that's why you see the cherry red spot. All right, what am I showing here?
The central retinal artery and vein, same sheath.
So you see too many crown burgers in that central retinal artery. You see it's massively arteriosclerotic and narrowed, but look at the sheath next to it. So remember, most common cause of central retinal artery occlusion is, arteriosclerosis. You've got a narrowed artery that's susceptible to emboli, but the most common cause of vein occlusion, arteriosclerosis of the central retinal artery, which causes stasis next to it because they share a common adventitial sheath. And here's an eye that has had a central retinal artery occlusion. The outer third, which receives its blood supply from where? Choroid, still intact. The inner 2/3 is wiped out. All right, this is the Greek Parliament building. This is the Evzon who guards the Greek Parliament. I sat there and looked at this guy for 5 straight minutes. He never blinked, so I don't know. I'm totally impressed that he could do that. He never blinked. They don't flinch. They change the guard. If you're ever in Athens, you got to see they change the guard silently in perfect step. It's pretty impressive. All right, we're going to talk about some macular diseases here. What are we seeing here?
Lots and lots of soft drusen.
Exactly. So nice soft drusen all over the place there. And when we look pathologically, where are drusen located? Exactly. So if you think about the basement membrane of the RPE is the first layer of Brooks, technically it's even intra-Brooks, but it's certainly underneath the RPE. And then you get overlying degeneration of the RPE and secondary overlying degeneration of the retina. What are we seeing here, Becca?
So we've got an area of hemorrhage. I can't quite tell if there's vessels overlying it, but certainly you can see the extensive edema around it. Looks to be subretinal.
So you see that kind of a yellowish, grayish look in the periphery there. That means it's even sub-RPE when it starts. Then as it gets more darker red, it breaks through under the retina. So this is a patient with macular degeneration, subretinal neovascularization. All right. I like that one. So, okay. This is the temple at Delphi. This is where the oracle lives. And so you would go to the oracle and you would say, please give her an offering. And you'd say, tell me what's going to happen. And the oracle would say things like, I see the destruction of a great empire. You'd say, all right, we're going to, kick butt. And so then they would go and invade and they'd get their own butt kicked. And so the oracle was never specific as to which empire was going to be destroyed. So you have to be careful when you get information from the oracle that it be more specific. So this is where I go and I ask how the residents are going to do in surgery. So the answer is sometimes a little cloudy. All right, optic nerve. This is a normal optic nerve. What stain is this?
This is a trichrome stain?
Trichrome stain. So you see that the connective tissue stains blue, mesenchymal tissue stains red. You can see the pia, subarachnoid, the columns. This is an optic nerve seen in cross-section. What do we see in, course, sorry,
I
I
can
forgot to
answer
wipe
that.
out.
Papilledema.
Papilledema, that's a good intern question, papilledema. What are the signs of papilledema, though?
So you see paling, and you can't see the entry of the vessels to the disc as well. It's kind of obscured.
Yeah, it's not even paling, it actually is often darker staining because the blood vessels get engorged. So you see that the edges are elevated, you don't see a good sharp edge, you have a congestion of the vessels, you have little microhemorrhages. Now be careful with the term papilledema. Again, when I took oral boards, one of the guys was trying to pit me on this because by definition, papilledema is optic nerve swelling secondary to increased intraocular pressure. So when they show you a picture of just a single disc like this, you say, this is a swollen optic disc. And then if they say, well, what's the differential? Well, if this were bilateral and had increased pressure, we would call it papilledema. But you want to be careful because they'll always try to nab you on that on boards. Here's the swollen disc seen pathologically. Now, in the movies and TV, you always see the audience place where they can sit and watch a surgery going on. I've never seen that in an operating room I've ever been in my life, except in Russia. They had one when Fyodorov used to operate. You could stand up and watch it in the peanut gallery. But on TV, they're always up there looking down on the surgery and discussing it. So, never seen it happen. All right, so remember, the glaucomatous nerve is the opposite of a papilledematous nerve. So glaucomatous nerve is actually excavated and coming down. All right, Chris, what are we seeing here?
So here we're seeing a little girl that left eye, so she has ptosis on the left, and then that left eye looks a little low as well.
A little low and almost a little prominent, kind of, a little proptotic. And this is what we find on the specimen.
So this looks like tumors on the optic nerves, like an optic nerve glioma.
All right, so glioma is the most common optic nerve tumor in kids. Remember, there's astrocytes in the optic nerve, and so this is a grade 1. It's called a juvenile astrocytic glioma. It's a grade 1 astrocytoma. It's intrinsic to the nerve itself. It's more common in kids. And what are these called? Little cytoplasmic eosinophilic staining inclusions.
Gosh, I don't remember that.
Rosenthal fibers, so named after Rosenthal. All right, and here we have, this is an older lady.
So this is an external photograph. In the right eye, you can see some injection of the lateral conj, also a fullness in the lower eyelid. Looks proptotic with inferior scleral show.
We do the scan, what are we seeing here?
So we see enlargement of the right optic nerve, so concerned for tumor here. If it's a lady middle age, we're concerned for like more of like an optic nerve meningioma.
So if you see, this is what we call the tram track sign. You can see the nerve still in the middle, and then you see the thickened tumor tissue around it. So that's a sign of a meningioma. So it doesn't grow from the inside of the nerve, it grows around the nerve, and that's called the tram track, like the 2 tracks on a tram going up the mountain. So this is indeed a meningioma, and for bonus points, what do we call these?
Not Rosenthal fibers.
Nope.
Sonoma bodies.
Samoma with an M, not Sonoma, the part of California. So Samoma bodies, Samoma with an M, Samoma bodies. All right, so I know you guys are just about daydreaming there, so I'm gonna put electrodes on you real quick here. Retinoblastoma, we just went over this a week ago, so just realize the 2 growth patterns, which are, Chris?
Endophytic and exophytic.
Endophytic and exophytic, and what do we see classically?
You see calcification, necrosis.
Okay, so necrosis, dystrophic calcification, rapid growth of the tumor cells. What's the most common pathological?
Get the rosettes.
Yeah, and whose names go on that? Yeah. Flexner-Wintersteiner rosettes. So, the rosettes. And when it spreads how?
nerve.
Through the optic nerve. So remember, when retinoblastomas spread, they spread via the nerve. And I know your brain is almost full. You have to sleep with your hats on. So malignant melanoma, real quick, what's the most common growth pattern that you see in these of the choroid? What is the shape? What vegetable is this shaped like?
Mushroom shape.
Mushroom shape. So it'll start in the choroid, pop through Brooks membrane, grow under the retina in a mushroom shape. So what is the classic classification we use to describe these from the 1930s? It's the calendar classification. And so calendar classification, this is spindle A. So technically not really a melanoma. Spindle-shaped, indistinct cytoplasm, more of a nevus than a melanoma. You can get spindle B cells, and then you can get really nasty epithelioid cells. And that's really important prognostically. Becca, how do they spread when they spread?
Hematogenously.
Well, but how do they get out of the eye? Through any emissarial channel. So they'll usually go out along the vortex veins and get out, but you can go out where any artery is coming in, any vein is coming out. So they go out through the emissarial channels, through the sclera. Where do they spread when they go? To the liver. And so we say goodbye to Delphi again, and good luck on OKAPs.